Right. Good afternoon. Thank you both for coming. Secretary of State, obviously you're well known to people following from outside this room, but Sir Chris, would you mind just introducing what your role is?
Yes, I'm Chris Wormold. I'm Permanent Secretary of the Department of Health and Social Care.
Thank you very much. We're here this afternoon to look at the state of contingency planning in the event of no deal. And we started our last with our last panel considering the implications for pharmaceuticals and medical devices in particular. Secretary of State, one of the things that will most concern people watching this is how well prepared are we in the event of no deal to make sure that products are on the pharmacy shelf when people arrive with their prescription. We know, for example, the situation that has arisen because of the shortage of EpiPens, because of an issue in the manufacturing supply chain.
Yeah.
The implications of that happening across the piece in a number of different products, the implications of that would be enormous, both for individuals and for the entire healthcare system. Could you perhaps give us a picture of where we are now with all this?
Thank you, yes, and thanks for the opportunity to return to this issue. Clearly, it is something we're focused on very closely in the department, and indeed we discussed at Cabinet earlier today, because this is obviously a cross-government issue. The situation is that we do not expect a no-deal Brexit as our central expectation, and I remain optimistic that we'll be able to get a good deal. Nevertheless, as a responsible government, we ought to be preparing, even though we don't see a no-deal Brexit as the most likely outcome. The engagement with the pharmaceutical industry has been very positive. There's an awful lot of engagement that's going on, and yet more that needs to be done. The plans that we set out, that I talked to the committee about in July, are proceeding. I'm confident that if everybody does what they need to do, then we will have the unhindered flow of medicines and supply of medical devices that we want to see. We've published a series of technical notices in order to support the actions that will be needed in order to see that happen. And we need to make sure that we in government do what's necessary to support the unhindered flow of medicines in the event of no deal, also that the pharmaceutical industry does, and that the NHS is prepared, although I'd stress again, as I did last time we met on this subject, that it is the responsibility of the pharmaceutical industry, of course supported by the government and the NHS, to deliver on the contracts that they have. Having said that, we're working very closely with them and prepared to support them to make that happen.
Right, Secretary of State, it's 157 days now until we're set to leave. We heard that some of the contingency planning, for example, around refrigerated warehousing, it would take a year to construct. So time is not on our side here. How confident are you that people will actually find they've got the medicines that they need on the shelf, and that hospitals will have the complex biologics and other diagnostic tools that they need?
Well, I'm confident that so long as everybody does what they need to do, then we will have that unhindered supply of medicines. However, there is an awful lot of things that need to take place. You mentioned, for instance, the storage needs and the need to stockpile. We've issued today an invitation to tender for additional storage capacity. The storage capacity we're looking for is either additional storage that's ready for Brexit-related demand, or space that can be converted to medical storage, or the new facilities that you talk about. So we are confident that can be delivered in time for March next year, and hence we're getting on with it, even whilst we're proceeding with the negotiations, which I very much hope will lead to a deal and to be no need for this stockpiling. We're getting on with making sure we've got the plans in place and the actions that we need to take now in order to have the mitigations in place, we're taking.
And have you made now an estimate of the total costs of this? Because there are costs in very, very many areas, as we've heard from our earlier planning, not just in terms of storage capacity, but right through the entire system in terms of sort of switching the way that BSI may need to switch to different European certification bodies in the devices chain. There are, in every single area, every part of the supply chain, there are issues. Have you made an estimate of the cost?
Well, the cost to taxpayers is related to the additional support that we will give to industry to ensure that they can have that unhindered flow of supply. Now, we are not going to double pay for medicines. So there have been some figures bandied about that simply add up the total cost of medicines that need to be stockpiled. And said that is the cost of medicines in a no-deal scenario. That is not the case because we buy the medicines once, and if they have to be stockpiled for a period, then there is a storage cost to that.
Yes, there's an upfront cost.
Exactly.
But there are other costs in terms of actually, we heard, for example, bringing on a greater capacity for refrigerated lorries, warehousing at every stage of this. And industry isn't clear about how they're going to be reimbursed for those extra costs. And they're particularly concerned about the impact on small companies.
Yes.
And so how are you going to make sure that we don't see smaller companies going under because they're having to bear these extra upfront costs?
Yes.
And at the moment, they have no certainty about how they're going to be reimbursed.
So we want to
we
want to ensure that the support that goes from taxpayers for this is as well targeted as possible. As you say, the bigger suppliers are, in many cases, were already undertaking this sort of activity before we announced that we were going to potentially had support available. The ITT that has been published today will lead to costs that we expect to be in the low tens of millions of pounds to the taxpayer. I haven't got an exact figure for it because we're buying this in this storage capacity from the market, and in some cases it'll be constructed. Of course, we'll be transparent about those costs once we've made agreements, but we don't have a figure in advance because we want the cost to be as low as possible.
No, I understand that. Sorry, I beg your pardon.
Add maybe helpfully. What we're actually doing right now is almost a product by product discussion with industry, following the Secretary of State's letter in August. The industry comes back to us with a lot of information, and then we are discussing with them what is the right answer, basically at a individual product level. For some people that will be stockpiling. There may be some where you need to do air freight for some of the reasons that you've described, and we won't take decisions on individual support till we've actually completed those discussions. So a lot of these questions, it's quite difficult to give a sort of generic answer because we have to be working down at the level of individual products.
But what we heard is that there are a number of companies now who are having to invest quite heavily in contingency planning now.
Yep.
And if they're small companies with tight cash flow, that has very serious implications for them. Are you on a company by company basis actually discussing with them how they can be kept afloat and supported?
These are the discussions we're having, and I'm sure you heard a lot of this from witnesses, and it goes throughout our preparations. There is, of course, a big desire from industry for certainty across a whole range of things. Now, the nature of where we are and the possibilities of no deal mean across a whole series of things we are not able to give the certainty that people want. We think we've got the right processes to deal with that, but we can't get away from there is an underlying uncertainty there.
But is your contingency planning also factoring in that some companies may go under or simply move abroad?
Companies will need different support on a drug line by drug line basis and a company by company basis, depending on the scale of the company. We've already seen a swifter reaction generally by the big companies, although some small companies have also been able to move quickly. But you can't give a general answer to that. There's over 400 of these companies with whom we're engaged. We have a team in the department doing that engagement, and the instruction to the civil service team who's doing this that I've given is to ensure that for every single line of that we have a plan in place that's appropriate to the medicine and, for instance, the shelf life. Some of the shorter shelf lives need a different treatment, and consistent with the cross-government planning assumptions that we have for the time scales.
So just to press this point, if they come back to you and say that we're facing upfront costs preparing for a no-deal scenario, because they have to get on with that now because of the lead times involved, are they going to be directly reimbursed, or how do you envisage the mechanism for
we have that
them?
discussion on a company-by-company basis because we want to protect value for money. It's very important that this process isn't gamed and that we make sure that companies are appropriately supported. But that support is available if it's needed, but we get into quite a level of detail. Now, most of these companies are long-term suppliers to the NHS, so we can have a relatively open book discussion with them, and they want to be long-term suppliers to the NHS in the future, and so we expect a collaborative approach, and that's what we've mostly got.
Thank you. It certainly didn't come across from our first panel that there was certainty about how they were going to be reimbursed, I have to say.
Neither of us have said that. That isn't.
But you said that there's a case-by-case,
yes,
product-by-product discussion going on, but that wasn't the impression that we were given, that they had any clarity about how they were going to
it would be, I'm sure that for a company in these circumstances, it might be easier if we simply wrote a cheque, but we're not going to do that because we want good value for money. For the support that we give.
Right. Thank you. I'm going to come to Ben.
Secretary of State, you could have avoided a lot of this cost and disturbance if you'd gone for a Norway-style option in the first place, couldn't you? And that's what the industry has said to us last year. Full regulatory alignment, customs union, single market. Is it inconceivable that you might change your minds as a government and reach that sensible option in the next few weeks?
I think that we've got a good deal on the table, which, as the Prime Minister said yesterday, is 95% agreed in terms of the withdrawal agreement, and I'm confident that we'll be able to land that deal, and that deal includes the sorts of associations in terms of medical supplies, which will allow us to be very close to our European partners over the long term. So, of course, there are lots of different views on exactly how Brexit should be put into place, or indeed whether it should be at all. My view is that the plan that the government's put forward will give us a good Brexit deal, and I'm confident that we'll get there.
Very close, but it doesn't provide the full regulatory alignment which the industry has said time and time again that it needs, does it?
It does provide for full regulatory environment alignment at our choice, and I think that there's no reason why we should. Let me put it more strongly than that. We want to ensure that there is no reason why it should be more difficult to apply for licences than now, and indeed, in some instances, it may be possible to accelerate the process. Today we've launched, for instance, the Accelerated Access Collaborative. This is not a Brexit-related policy, but it is about accelerating access to new innovations across the NHS. Actually, moving to an MHRA-led process gives us the opportunity to do that. So I think that I understand that lots of people have concerns, but the reassurance I give is that we're going to ensure that new drugs, under a deal or no deal scenario, have a passage through the regulatory system with no more burdens than in applying to the EMA. And I think that we can have an excellent system for drug regulation in the future. We've already set out in detail how we're going to ensure that we recognise batch testing done by the EMA, and we have a consultation out right now on how we can ensure that those who apply to EMA can apply in the same terms to the UK regulator, and so I think that this is. I hope I can give some very significant reassurance that it'll be just as easy to apply as now, if not more so.
A moment or so ago that you said that you were confident, was the term you used, about the continued supply of vital medicines and medical equipment in the event of a no-deal Brexit. That's not language that Sir Chris would use in front of the DEXU committee last week. I wonder why you're more optimistic than he is.
Funnily enough, we discussed this before arriving, and both of us say exactly the same thing, which is, well, I'll say it and then why don't you say it? We are confident that if everybody does what they need to do, then we will have the unhindered supply, and I am satisfied that everybody currently is doing what they need to do. Of course, there's a huge amount more effort that's needed between now and the end of March, should we be in a no-deal scenario, but I'm confident that we can get there.
Yeah, I mean, when I was discussing this with the Exiting the Union Committee last week, I was actually making a more general point that I almost never use the words guarantee or confident to do with anything in health. It's a very big and complex system in which a lot goes right and some things go wrong. So, as a sort of general rule, and this is the point I was making, I don't do that. As the Secretary of State says, if everyone does what they need to do, we should be in a good place. The uncertainty, which again we discussed at the Exiting the Union Committee last week, is around not what the government is doing, and I'm completely confident the government's doing all the right things, as you would expect. The issues we were discussing were about what the French reaction would be, which is obviously something that we don't control. That's where the big uncertainty in this is, that you will see both from the industry side and from our side.
But I noticed that in spite of the prompting you just received from the Secretary of State, you weren't prepared to say that you are confident.
No, I'm confident that the government is doing all the right things, and that if everyone does what they're supposed to do, everything will work. That includes the uncertainty around how the French will react. What we've seen, and I said this to the Exiting the Union Committee last week, is everything we have seen in the discussions is health has not been a vexed issue across us and our partners, and everything we've seen suggests that everyone, both here and in the EU, wants to ensure that vulnerable people are protected and nothing goes wrong. If that continues, and everyone does the right thing, as the Secretary of State has said, then all these issues ought to be mitigatable. So I'd completely endorse what the Secretary of State has said.
And is your advice to the industry still that it will require 6 weeks of stockpiling to ensure the continued supply of medicines and medical devices for NHS patients?
Yes, that's our advice as set out in the technical notices based on a cross-government assessment. We, of course, always keep that under review.
Might that change?
Well, we keep it under review, and we set out when we publish the technical notices that we'll keep it under review according to the assumptions about that feed into the decision on for how long there might be blockages.
What's that 6 weeks assessment based on?
Well, it's based on the cross-government assessment, including from the Foreign Office, Department for Transport and Cabinet Office assessment of what the timescales should be.
So it takes into account what the Department of Transport has said about the likelihood of the M25, or whatever it's called, the one that goes to Dover, becoming a lorry park.
It takes into account all of these things. It's a cross-government planning assumption. And, of course, that's kept constantly under review. And there is that's the central assumption of the length of time that we need stockpiling for. Of course, there are many detailed other planning assumptions that are being worked on to ensure that we have as good a plan as possible. Now, a plan, there's two elements to the civil contingencies work. both the plan in advance and then ensuring that we have as smooth as possible system in place for reacting to events as they occur in the event of no deal. Because there'll be if we're going through a no deal Brexit, there'll be a series of changes that occur as we leave the EU, and we'll need to be able to respond to those. But that machinery is in place, and it's based on existing procedures that are operated when there's a civil contingency
because
issue.
6 weeks implies that you're confident that within 6 weeks of a no-deal, cliff edge Brexit, you would be able to establish completely alternative supply chains for all of the stuff that we need, because the stuff in the warehouse is going to have run out by then.
The 6 weeks is the planning assumption for how long we will need to. We'll need stockpiles of medicines before we're able to resume supplies through either because the blockages at the border are relieved, or that there are other routes in place. So, for instance, for short life isotopes, in that period, we will switch to airborne supplies, and we'll have to, because you can't get them in quick enough if there's blockages at the border. But likewise, there will be there's work ongoing on the alternative ways of ensuring that there are supply chains, even in the event of a continued blockage.
We heard earlier from one of the industry witnesses that you're going to have to use emergency powers to allow pharmacies to change patients' drugs without the consent or consultation of their GP. Is that something you're aware of and are planning to do?
That isn't something that I'm aware of, but what I'd say is that there is other than this, there is a normal procedure, as demonstrated now with the shortage of EpiPens, which is for an issue to do with their manufacture that's completely unrelated to Brexit, which demonstrates that we constantly, in the UK system, have a series of shortages of different types of medical equipment or drug. That is normal. In fact, when I asked the question, when did we last not have a shortage, I didn't get an answer, because it's a standard situation that there's a shortage of one or other piece of equipment or drug. And the response to such a shortage can be both to look for alternative supply lines and also to take a clinically based decision on the appropriate reaction to the fact that whatever it is may not currently be as available as we would like. So this is a part of the department's work that is in constant use and constantly being tested.
Just to make one observation to you, though, that having been on the receiving end of when that kind of thing happens, as a clinician before I came to Parliament, it takes up an inordinate amount of clinicians' time and pharmacists' time chasing around for alternatives. If that happens on a grand scale, it's okay when it happens occasionally with one or two products, but if it's happening for many products all at the same time, that's, I think, what concerns a lot of people.
Well, we're trying to reduce the amount of products that'll happen with all the planning work that we're doing now.
Paul, did you have any further points?
Sorry.
Thank you. Andrew and Martin wants to come.
Yes. Can I just return to the issue of cold storage? Because in the last session, we learnt that half the new medicines licensed last year require cold storage, and we also heard the point the chair made earlier that we were also told it currently apparently takes around a year to get new cold storage up and running. Now, you may have given an answer when you mentioned, Secretary of State, on isotopes, that we'd have to get them in through airborne means. Is that part of our planning assumptions for those medicines that require to be refrigerated through their entire distribution process from manufacturer to the patient?
Not necessarily, no. The airborne route is mostly, but not entirely, focused on short shelf life especially isotopes that degrade, but those drugs which you can't stockpile, essentially, those drugs or treatments that you can't stockpile. We can use refrigeration for drugs that you can store. And I don't accept this, the point of evidence that both you and the Chair have raised as a premise that it takes a year to put up refrigerated sheds, not least because we can use now additional storage that is already existing. That's part of our tendering. Also, we can convert space to medical storage standards that currently isn't, and you can build new facilities. Now, it may be the case that that somebody has had an example of where it has taken a year, but you can do it quicker.
Okay, that's helpful. Thank you for that. We also had quite a lot of our previous discussion focused on the issue between of the issue surrounding current British standards and European standards, and how that would work in the event of a new deal. And that was a particular concern raised by Johnson & Johnson. What's the department's thinking on how we deal with that issue in terms of UK certification and EU certification, not least in respect of actually the 46 million items of medicines that leave the UK to go into the EU, as well as obviously the 37 million items that come into the UK?
Yeah, I mean, I get
Is this under a no deal or under a deal?
Well, under a no deal scenario. And I think it's going to need legislation as well, and I don't know if you say something.
Well, I mean, I gather Johnson & Johnson were raising an issue particularly around stitches, which I have to say I don't know the specific answer to, so I'll go and look. But the general principle we are working to is anything that is currently licensed in the EU, we would license in the UK in any circumstances. The other way around is obviously not under our control. In a no deal, what the EU chooses to license or not license.
And sorry, that licensing within the UK. I mean, that is something. Does that require legislation? And what's the time?
I don't think it requires legislation.
We can pass it.
I mean, as I say, I'll check the specific.
The legislative requirements will be dealt with under the Withdrawal Act. Because the Withdrawal Act provides for us to change a requirement for EMA regulation to a domestic regulation, which will be done by MHRA. So we have the provision in place for those legislative elements that are needed. But the central point is this: we will effectively unilaterally recognise EMA approvals and EMA batch testing to make sure that there is no barrier in this space.
And is that a Secretary of State power that you can recognise that?
Yes, and we will align MHRA processes so that people applying for a new drug in the future won't have to have any additional burdens to apply for MHRA licensing, and it will have to be MHRA licensed because the power would come to a UK organisation, but we'll make sure that the process is aligned so that somebody going for an EMA approval will also be able to go for an MHRA approval, and we can do that unilaterally as well.
Okay, that's it. And just the last...
I mean, I want to give the maximum possible reassurance to pharmaceutical companies who may be who are interested in this area and may be watching, and my maximum possible assurance is this: if your drug can be approved by the EMA, then it is going to be approved in the UK under a deal or a no deal scenario.
I'm sure that will be very reassuring, not only to people to people in the room as well as watching from outside. The last area I just wanted to raise, I was a little bit surprised to hear from the Saffron Cordery of NHS providers that there has been some reference to possible difficulties around feeding patients in hospital in relation to food. She said this had been mentioned in some of the technical technical notes. Can you give us some reassurance on?
What we said, we had a communication with NHS hospitals where we are asking them to basically check all their contracts for any EU exit issues, and we provided them with a toolkit to do so. In the case of food, that's one of the areas that we're doing centrally rather than asking individual hospitals to do. So we are asking all the main suppliers of food to hospitals to ensure they have contingency arrangements in place for anything that they currently source from Europe. So that's a discussion the department is having. Okay. I suspect that's
and I think the issue also covered nutritional supplements as well.
Yeah, I mean, what I would say, when I was reading the letter just before I came in, there is a colossal list of NHS suppliers about whom we are asking the same questions. There's nothing specific about food. We want to ensure that we have asked that question about the vast range of NHS suppliers, either nationally or trust by trust. And what we were doing was dividing out, these are the ones where we're going to have a conversation nationally, and anything else that you do, you need to be having a local conversation.
You said earlier that health is a tricky business sometimes, so you don't like using the phrase, I want to give complete reassurance, but what words would you choose to give to sort of families listening who know they're going to have
see everyone's favourite question
in hospital that they're going to be fed?
We are clear we are putting the right mitigations in place. I am not going to predict the future, and I never do, but the government has put in place all the right measures to ensure that we can manage these situations. As the Secretary of State was saying, pretty much any contingency we do in the health service has two parts. It has a prepare bit and it has a respond bit. We think we're in the best place we can be to do both of those things, but the latter, the respond bit, as with any other piece of contingency planning, has a level of uncertainty to it. So I think we can be completely confident that the government is taking all the right steps, but one of those steps is to be prepared for things that we don't know are going to happen yet.
Thank you.
Martin, you had...
Thank you, Chair. Secretary of State, you referred earlier to what the Prime Minister said yesterday about a deal 95% complete. In the remaining 5%, what issues concerning your department are there?
There are... I want to give you as full an answer as possible. As far as I can consider, other than the position of the Irish border, which is clearly one of the tricky remaining issues, and over which there is a small amount of flow of medicines, I don't think there are any, and there are certainly none that are health specific, where the main incidence of the concern is around health.
Because we heard from the previous panel that expressed some concern that the EU27 were not engaging in detailed discussions because of some substantive issues. So
not substantive issues to do with the responsibilities of the Department for Health and Social Care.
And one last question: the position of UK citizens receiving health treatment when in the EU27, is that now resolved?
Well, it would be. It's resolved under a deal scenario, so long as we land a good deal. In a no-deal scenario, we will be publishing very shortly a healthcare reciprocal arrangements bill, and we are undertaking bilateral discussions with the main countries in which UK citizens reside and from whom their citizens live in the UK, in order to get to a position where people's health is looked after wherever they live.
Thank you.
Thank you. Did you have any further follow-up points on this, Ben? Just turning to the point about regulatory alignment. I mean, this is something this committee has welcomed in the past, having regulatory alignment for the reasons that you set out. In the event of no deal, would it be the government's intention, even in no deal, to continue with regulatory alignment from our end? Just to be absolutely clear on that point.
Yes.
Thank you. That's very helpful. We're going to move on now to further points on contingency planning. Andrew, have you had all your questions?
Some more points on staff.
Yes.
I don't know if we're
Thank
coming
you.
on to that
Yes,
yet.
please do,
But
yes.
So we have
Very
to go into that
happy to
now.
move on to that.
Secretary State, you told us
Yeah.
in House Questions earlier today that I think if I heard you correctly, you said there were 4,000 more EU nationals working in the NHS and
Yes.
the social care system
Yes.
than at the time of the referendum. But we heard in the earlier session, I think the number of nurses applying to work in the UK from the European Union countries has declined quite severely. I wonder if you could just give us a little bit more detail
Yes.
of the breakdown. As obviously it's a net overall increase, but it's gone down on nurses. So
Yes.
could you fill in the remaining gaps in
Yes.
terms of what's happening, please?
So I said more than 4,000 on the floor of the House earlier because I didn't have time to turn to this page of my briefing, which says that the overall number from the increase in EU staff in the NHS from June 2016 to June 2018, which is the latest figures I have, is 4,367. That's an increase of 580 in doctors, of 205 of ambulance staff, 1,618 scientific, therapeutic and technical staff, and 1,910 support to doctors, nurses and midwives. Now, the nurses and health visitors number and midwives has fallen. At the same time as the referendum, we introduced stronger language testing. So my analysis, having looked into this in depth, my analysis, both implied by these figures and once you dig into why the number of applicants from the EU for nursing places in the UK has fallen, is that it is due to the impact of the language testing rather than the impact of the referendum.
Right. Could you, I mean, obviously having enough nurses on our wards is absolutely critical to everything we do in the NHS.
Yes.
And we know there's a significant need in that area
Yes.
now. I know immigration policy per se is not in your particular brief, but could you say as much as you're able to in front of this committee about how you envisage post-Brexit immigration in respect of health and social care needs in the UK,
Yes.
as far as the EU 27 countries are concerned?
Yes, well, our proposal is that we're going to have a global skill-based immigration system. We currently have an exemption to we have an uncapped system for attracting doctors and nurses from the rest of the world. Outside of the EEA currently, and which I think is great. And I want to see the brightest and the best doctors and nurses from around the world continue to come to the UK as they do now. Now, the language testing point is a matter for the Nursing and Midwifery Council rather than from the department. They are, of course, independent. But there's a need to attract doctors and nurses from around the world, as there always has been in the past.
Okay, and I'm very pleased you're very keen on technology as a Secretary of State. We did learn earlier there's an issue with the settled status can't be applied for on Apple products. Are you in the course of being able to sort that out? We heard that from the Deputy Chief Executive of NHS providers. Apparently you can apply for it on Android products but not on Apple ones.
Well, and you can apply for it on a desktop computer. So that is something that I've talked to Home Office officials about. And but there are there's lots of different ways that you can make the application, and the application is relatively straightforward. And so, if like me you have an Apple device, then you need access to to a different device or a desktop.
Okay, but you will make sure that this doesn't become a problem in terms of resolving settled status, and you'll keep an eye on the fact that EU staff that need to go through this process can do it in a timely and straightforward manner, and that there aren't bottlenecks and delays, because that obviously will just add to anxiety.
On this one, I'm happy to take instruction from the committee.
The only thing I'd add, and obviously this is mainly Home Office business, but they've of course been trialling their settled status systems, mainly in the NHS and in universities, and are going to continue to do so. And they've been very, very clear that the NHS is one of their key customers, and that therefore testing all these systems in trust. We've been testing in Liverpool. We're going to go on and test in some other areas, so that we are sure that it does work for the NHS as well as all other groups.
Do you know if they are trying to get it to work on Apple products? And are you asking them to do that?
Yeah, this will go rapidly beyond my technical expertise, but as I understand the issue, it's about what Apple is prepared to support as opposed to what the government is doing. Now, I know the way that a number of NHS trusts have been dealing with this is just to make sure that Android devices are available in the hospital, to ensure that all staff have availability. There are a lot of Android machines out there, and there are things that employers can do like that to ensure that there aren't any technical barriers in the way that the Secretary of State's described.
Okay, thank you.
Thank you. And Paul, and I want to bring Lisa in.
Secretary of State, you're a Secretary of State that likes to ask questions of your officials. You often refer to the kind of questions that you ask.
Yeah, there you are.
Now, you must have asked the question around not just the number of staff that are coming from EU countries into the NHS since the referendum, but also the rate at which those staff are coming here. And you said today 4,367 more staff than June 2016. You've previously also said that there are 1,300 more staff than March 2017. Now, if you work out the rate from the numbers that you've given, in the first 9 months after the referendum, there were 356 people a month coming. But actually, since then, there's only been 81 people a month coming. So we cannot attribute, if you say that the language test was applied at the time of the referendum, in the 9 months after the language test was applied, there were still 356 people a month coming. It's since then, it's since March 2017, it's the recent figures, there has been a massive decline. There's been a 77% reduction in the number of people coming. That's got to be because of the government's mishandling of Brexit. We all know it. It's all on the ground. When we listen to people from European countries, they don't want to come here because they're afraid.
That's not my reading of it, because you've you've compared apples and pears in that, because the change in the language requirements only applied to nurses from the NMC. And nurses, health visitors and midwives is the only category where the number of EU employees has fallen. It's risen in every other category, whereas the way that you described the figures first was describing the totality of EU employees, and then the second time round was referring to the language requirements which have only applied to a subset. So my analysis of all of the figures, rather than a partial set, is that given that the numbers everywhere else have gone up, but in the one place where we've applied an additional, the NMC have applied an additional language test, the figures have gone down. And to me, there's a straightforward logic to that, and that's confirmed by diving into to ask the questions of why the numbers have changed.
Do you accept that there's been a 77% reduction in the rate of people coming?
I've got the 2016 and the 2018 figures in front of me. I'm happy to write to you with a more detailed breakdown of the statistics.
And would you be concerned if there were a significant reduction in the rate of staff coming here from EU countries?
Well, I'm keen to ensure that we can, as we always have, attract the brightest and the best people from around the world to work in our NHS. We've got to remember that the majority of non-UK nationals working in the NHS are from outside of the EU. And sometimes this debate takes place as if the UK and the rest of the EU were the only places on earth. That's not the case, and we attract many brilliant professionals, both clinical and non-clinical professionals, from all over the world, and they're extremely welcome, and our NHS benefits from them.
Do you have any points?
Will EU staff who have lived in the UK for less than the 5 years be eligible to apply for pre-settled status?
Have you got an answer to that? Look, the settled status policy is a Home Office policy. So I don't want to give an answer without looking at the details of it. You might want to ask the Home Office.
Write to the committee.
Yeah, of course.
Or find out.
I'll give you my understanding, but
Yeah.
I may need to correct it once I've checked the actual position. I mean, as I understand it, there's a time limit on when you can apply for settled status, but not an end point. Right. So that if you're here, you can apply at whatever point you reach the relevant checkpoint. I don't know if it's 5 years. And the Prime Minister has made very clear what she said about people who are already here and working in the NHS and elsewhere. I mean, I'll check the exact technicalities. That's my understanding of how it works.
If I read you my briefing note on this, the Home Office has launched the EU settlement scheme, a simple registration process for EU nationals who arrive in the UK to live before the end of 2020 or 29th of March 19 in the event of no deal, to remain living in the UK with broadly the same rights as they currently enjoy. The Home Office tested this scheme with all health and social care staff from 26th of November 2018, giving them earlier access than the rest of the population. So my that's my understanding. So I didn't recognise the 5 years point. That states that everybody living here will be able to apply for settled status.
And just a quick question about social care staff, because obviously, when we're moving from health to social care, this is going to be a huge priority to get this right in the future, as well as making sure that social care staff can stay and work. What is the government going to be doing to try to ensure that we're training enough staff here
Yes.
who can become social carers, and that we do provide opportunities for people
Yes.
in the UK to take on that really important role?
Yes, I think this is such an important issue. I want to make sure not only we provide for the training that people want to work in social care, but also that we increasingly make the roles in social care really attractive ones. And that is the case in some providers, but it isn't always the case across the board. And we have a whole strand of work in the department for making the jobs in the health and social care system more attractive and yet more rewarding. Too often the jobs are rewarding and mission-driven because you're helping other people, and that's very rewarding. But despite the system, and I want to see the system support rather than get in the way of people loving their jobs.
Thank you. We know that there are 104,000 roles in England, or 8% of the total workforce in social care are EU nationals. Obviously, their income is going to fall underneath any kind of level where they'd automatically be able to apply to come here. Are you concerned about the impact on social care and for people who use social care after we leave the European Union, of making it more difficult for people to come here?
Well, like the NHS, there are more people from outside the EEA than from non-UK, EU and EEA countries working in social care. So, again, our approach to this has to be global. Part of the answer is, of course, more training domestically, so that people domestically can support the system.
Yes, I think we'd all agree on that. But there is going to be a shortage, and one of the reasons why it's so helpful to have staff from the EU is the ease with which they can come here. Have you made an estimate of the extra costs that will be faced by the care system and the NHS in actually the visa arrangements involved? I mean, there will be a significant extra cost.
I haven't got a specific estimate of the visa costs involved. Of course, visa costs haven't been set, and the immigration policy and white paper hasn't yet been agreed, but it is something that I'm working closely with the Home Office on.
Mm-hmm. But have you made an assessment of how long it takes to actually facilitate staff coming from outside the European Union as opposed to...
Well, the part of what we want to do with the future immigration system is make those timescales shorter and easier. Because there's the cost, the direct financial cost of getting a visa, but there's also the bureaucratic time that it takes.
So you're intending to look specifically at how you can reduce that?
The bureaucracy around getting visas,
and
yes.
Have you had any discussions with your colleagues in the Home Office about, because obviously it was very welcome that the changes to the Tier 2 visa arrangements and that they were uncapped, but that's time limited, I understand. Do you know how long that's...
No, it's not. It's not. It is... The Home Office answered a question in the standard way they do, which is that all visa arrangements are kept under review. That was interpreted to mean that this was a temporary scheme. We have no intention of changing it.
Right, thank you. And just to go back to your earlier point, where you seem to indicate that the drop in applications is primarily due to language testing. There's no doubt that had an impact. But this committee, during our nursing workforce inquiry, heard more than once from nurses in tears telling us about how they no longer felt welcome working in the UK. Do you accept that there has also been an impact of the decision to leave on the applications from the EU?
Well, look, like everybody, I've heard stories like that, and I hate the fact that some people have felt less welcome here following the result of the referendum. And I want to welcome people who want to contribute, in an appropriately organised way from right around the world. So, of course, I've heard the same stories.
Directly from individuals? Have you been out and met staff from?
Well, I haven't.
Countries?
Look, I know there's people who feel like that. I'm trying to think of whether somebody within the NHS has said that to me directly, but I know that people feel like that. And I hope that one of the things that we can do as we land a deal is bring people back together across society. And I think that this is something that everybody needs to work on together, and the NHS can play its role as a really big employer. But the fact of the figures speaks for itself, which is that even though there are people who absolutely express those concerns, there are more people in the NHS from the EU than there were on the day of the referendum, and I think that shows that overall we remain an extremely attractive place to work.
But I agree, but we need to look at those figures in the context of the total employed population in the NHS, not just as absolute numbers and the rate, as my colleague has mentioned.
Of course, and look, I think that I'm an internationalist, right? I love the fact that we attract brilliant people here to the UK, and I think it adds huge value. I think that it's best that that's done in a controlled and organised way. But there's a lot of value that can be added, and most importantly, when people have come to make a life here, then they should feel welcome, and it's incumbent on all of us to play our part in that.
Thank you. Rosie.
Thank you. Government's indicated that public health protections and standards won't be traded away and that health partnerships will remain strong.
Yes.
Yet the last panel told us that in a no-deal scenario, the UK will be immediately excluded from the Centre for Disease Control, with all that means potentially UK residents are exposed to additional risk. I further understand that an EU-wide prescription medicines verification system is due to be rolled out in the UK in February 2019. That's called the Falsified Medicines Directory.
Yeah.
So what will happen to that system in the UK if there was no deal? Will we become more vulnerable to counterfeit medicine?
No, we are, for two reasons. The first is that, of course, we'll still be members of the EU when that scheme becomes law directly applicable from Brussels. And secondly, because although some European countries have a problem with counterfeit medicines, we do not have a large-scale problem, and the existing system works largely very well. Of course, I'm not saying, again, to take a leaf out of my Permanent Secretary's book, I wouldn't guarantee that there are no counterfeit medicines at any point, but in the UK, the figures show it's a very, very small problem, and we're determined to keep it that way.
What about the...
Shall I answer on your more general point about health protection? Health protection is already a world business. Our dealings internationally are partly through the EU, as you say, but they're also heavily through the WHO, which we remain and will remain a leading member of. In practice, if the result of exiting the Union is we are not involved in the EU systems, we will have to rely more heavily on our WHO systems, including the WHO. It has a European level of activity that actually goes wider than the EU, which we will remain a member of. So we will have exactly the same objectives for health protection. We will have to deliver them differently and use, as I say, our WHO membership more heavily if we don't have access to the EU one.
Slow down, it'd be diluted?
No. We will do what everyone else outside the EU does, which is work with the WHO. And much of our health protection work is already with the Americans and the Canadians and etc. And we will have to rely more heavily on those systems.
So you're really saying there'll be no disadvantage?
We'll have to ensure that there isn't. And as I said earlier, all these issues around health, there is no difference of alignment between us and our European partners. There's no advantage to anyone who's not cooperating on health protection and those sorts of issues. We'll have to do it in different ways and in different formats. But as I say, we're not envisaging, and as I said before, I hope this will continue. We envisage continuing to have a productive relationship with all our international partners, regardless.
Obviously, you've had discussions with Europe on these matters. What have they said?
Well, as I say, the discussions around health have not been that prominent or that vexed around these questions. Obviously, everyone's focus is on getting the right multilateral deal at the moment, so our discussions about what would happen if that doesn't work have been limited, but we would expect everyone to share the same objectives as us.
But what if your expectations are not met?
Well, as I've said, you have to respond to those. You respond to those circumstances. In the specific area that you're raising of health protection, there has always been, well, not always, but since its creation, a world system around the WHO. So we know there is a effective system that we're already a major part of that we can play into. So in that specific area, it's very clear what we would do. As I say, we would rely on our very active membership of the WHO.
I think, if anything, the Permanent Secretary is underplaying the role that the department plays globally on this. You know, our Chief Medical Officer is one of the leading figures in global health issues, and that there's absolutely no way that Brexit's going to change that.
Secretary, I know you have to go, but I'm just wondering if you could respond to the comments in the letter by a sort of galaxy of Nobel laureates that Sir Paul Mercer was discussing on the radio this morning, and actually give us an idea of how you're going to ensure that after Brexit that our research community isn't devastated.
Yes. So I'm absolutely determined to do that. I saw the letter, and The core part of the letter, the core argument in it was that we should get a deal, and I very strongly agree with that. In the event of a deal, I'm content that the deal that is on the table, that's 95% complete, will be a good one for the engagement of the UK with the rest of the EU in the future, alongside our engagement with the rest of the world. Now, we've already, on the financial side, we've already put more money into science than we could possibly lose from the European scientific programmes. So we will have a record level of government science funding next year, no matter what happens in the deal with the EU, and that is a great thing. Now, I appreciate also it's not just about the money, it's also about the collaborations. And I want those collaborations to be as rich and deep as possible. Of course, scientific collaborations are global as well by their nature. And I don't think anybody should try to reduce the level of collaboration because of the degree, because of the nature of the trade arrangements between two countries. That hasn't been the approach in the past, and I think that our global leadership on health research will continue, and I'm determined to do everything I can to make that the case.
That's very helpful, but it's also about the workforce as well, and the workforce being able to move here easily.
Yes.
Is that something that you're going to be having discussions with your colleagues in the Home Office about?
Yes, and it is when I say we want to attract the brightest and the best, clearly researchers and indeed their wider teams are a critical part of that. We're incredibly proud of the UK's advanced position in medical research, and we're going to sustain it and keep improving on it every year.
Thank you.
Thanks very much.
Meeting has ended.